Good afternoon. I'm Dr. Phoebe Thorpe. Thank you for joining us for August 2015 Public Health Grand Rounds on adolescents preparing for lifelong health and wellness. Let's get started, but first, housekeeping slides. Public Health Grand Rounds has continuing education credits available. Please see our Public Health Grand Rounds website for more information. We also are on social media. We have a special video called Beyond the Data that will be posted shortly after today's session. We are also tweeting today, so please use hashtag CDC Grand Rounds for all your tweeting needs. We have also partnered with the CDC Public Health Library to feature scientific articles related to adolescents and their health. The full listing is available at cdc.gov/library/SciClips. Here's a preview of our upcoming Public Health Grand Rounds session. Please join us live or on the web. And as an update, while there is still work to be done in polio, this past Tuesday marks 1 year without any new wild polio cases detected in Africa. In addition to our outstanding speakers, I'd also like to take a moment to acknowledge the important contributions of the individuals listed here. Thank you. And now a few words from CDC's director, Dr. Frieden.
Good afternoon, everyone. I worked for many years with an educator who said that one of the unfortunate things about being an educator was that everyone, since they've been to school, thinks they know how to run schools. I think the opposite can be true of adolescence. Since we've all been through it, we still have no idea how to get through it in a healthy way. Adolescence is a wonderful and terrible time of life. It's also a time of rapid change. For example, between the ages of 12 and 17, a parent can age 20 years. From a public health perspective, adolescents are establishing patterns of behavior. They're making lifestyle changes that may well stay with them for much or all of their adult lives. They're choosing whether or not to smoke, whether and how to use drugs and alcohol, whether to be sexually active and to have safer sex, what to eat, how much physical activity to get, all of the essential behaviors that will determine to a very great extent how long and how healthy their lives will be. They're increasingly independent, and with that becomes exploration, trying out new behaviors, and openness to influences from a variety of sources, many of them not so healthy. But that is why we see nearly a third of students reporting having tried 2 or more tobacco products, barely a quarter being physically active, but real progress, as you'll hear, in some areas. Things are actually getting better in terms of several of the risk factors. Whether it's safe driving or reduced alcohol use, teen pregnancy, but still much unfinished business and much more that could be much healthier and much safer. If we think about the influences on adolescents, they range from school to parents to community to peers, and that was not necessarily in order of importance. Societal norms and governmental policies can make a really big difference, and it's important to recognize that with this time of openness to change is also a time of opportunity for developing healthy lifestyle that will continue for a lifetime. Interventions that address multiple different risk factors may be more likely to succeed. It's true for tobacco, it's true for other programs, and interventions that cut across many different venues that can possibly influence behavior are also more likely to be effective. So thanks very much for our speakers. These are a set of very informative and stimulating talks, and looking forward to a very engaged discussion. Thank you very much.
And now for our first speaker, Dr. Stephanie Zaza.
Thank you, Phoebe, very much. And thank you, Dr. Frieden, for your opening remarks. Good afternoon, everybody. Adolescence is a developmental stage during which profound physical, intellectual, emotional, and psychological changes occur. Sexual changes, the onset of puberty and sexual maturation, also occur during adolescence. Adolescence generally corresponds to the preteen and teenage years and to the middle school and high school years. But different organizations select different age ranges for their own purposes, starting from 10 to 13 years and ending between 19 and 29 years. Our presentations today will concentrate on people 10 to 19 years old to focus on the unique developmental and health issues of this age group. There are about 42 million adolescents aged 10 to 19 in the United States, which is about 13% of the total US population. The adolescent population is racially and ethnically diverse. Our pie chart shows that Black and Hispanic adolescents, the green and aqua slices, currently make up more than 1/3 of the US adolescent population. Of these 42 million adolescents, 91%, or 37.8 million, are enrolled in public or private school. The Department of Education estimates that the dropout rate in 2012 was 7%, with significant variation by race. 40% of US adolescents aged 12 to 17 live in low-income families, 21% in near-poor families, and 19% in poor families. Black, American Indian, and Hispanic adolescents are disproportionately low-income, as are children of immigrant parents. Adolescent poverty varies by region of the United States, with the South and West having the greatest proportion living in low-income families. Estimates of homelessness among adolescents in the U.S. vary tremendously, from 500,000 to 2.8 million per year. Most homelessness among adolescents is due to running away. In 2002, SAMHSA estimated 1.6 million adolescents aged 12 to 17 ran away from home and slept at least one night on the street in the previous 12 months. The prevalence of running away increases with age. Adolescence, though, is a relatively healthy period of life. The overall health status of adolescents aged 10 to 17 is assessed in the National Health Interview Survey. In 2012, 97% of 10 to 17-year-olds were reported as having good health or better. Likewise, only 11% were reported as having some limitation of activity due to health issues. That said, there are some important preventable causes of death, illness, and injury. These are the 10 leading causes of death for adolescents aged 10 to 19. Injuries, whether unintentional or caused by intent, such as suicide or homicide, are the 3 leading causes of death, with some variation by race ethnicity. Other major causes of death are cancer, heart disease, and congenital anomalies. Injuries are also the leading cause of non-fatal morbidity among adolescents. In 2013, over 4 million unintentional, non-fatal injuries occurred due to mechanisms like being struck by something, falling, overexertion, and car crashes. In addition, it is estimated that there were over 260,000 injuries caused by non-sexual assault that year, and 8% of high school students attempted suicide. Sexual and reproductive health is also important during adolescence. Birth rates continue to decrease among teens, but in 2013, 273,000 births to mothers aged 15 to 19 occurred. Chlamydia and gonorrhea are very prevalent among 15 to 19-year-olds and constitute 27% of reported chlamydia and gonorrhea infections among all age groups. Most recent data for chronic diseases indicate that asthma prevalence is 10%. 14% of teens are overweight, and obesity occurs among 21%. So one way to address these health issues, of course, is through health care, and health care access and use among U.S. adolescents is relatively high in terms of insurance coverage and having a doctor visit. However, preventive health services, as represented by WellCare visits, the third bar on this slide, are underutilized. Important differences exist in healthcare access and utilization by race, ethnicity, age, gender, and socioeconomic status that Dr. Brindis will cover in more detail. And risk behaviors are the other way to address some of these health issues in adolescence. They're a major contributor to preventable causes of adolescent morbidity and mortality. Shown on this slide are 6 prevalent risk behaviors that correspond to the injury and chronic disease health outcomes that I showed earlier. Based on the 2013 National Youth Risk Behavior Survey conducted among 9th through 12th graders, 88% of high school students rarely or never use bicycle helmets, 41% texted or emailed while driving a car, and a quarter were involved in physical fights. Sedentary behavior continues to be a challenge among adolescents, with few getting the recommended daily amount of exercise. TV watching has transformed into other types of screen time, with excessive non-school work use of computers and other devices by 41% of students. And recommended nutrition guidelines, such as eating breakfast every day, are infrequently followed. Risk behaviors also contribute to reproductive health outcomes. Nearly half of high school students are sexually active, but few use IUDs or implants, the most effective contraceptives, and 41% did not use condoms, leaving large numbers of teens vulnerable for pregnancy or sexually transmitted diseases. And finally, substance use contributes to both short-term and long-term health risks and is prevalent among teenagers. 1/3 of high school students currently use alcohol, and marijuana use exceeds all forms of tobacco use combined, which is still prevalent among adolescents. Importantly, lifelong patterns of both risky and healthy behaviors are being established during adolescence, thus preventing the initiation of potentially harmful behaviors like smoking and binge drinking, and encouraging healthy nutrition and physical activity behaviors in adolescence can have lifelong benefits for health. In fact, reducing risky behavior and encouraging healthy behaviors are amenable to public health action. This chart shows national YRBS data for the 22-year period from 1991 to 2013, which demonstrate encouraging trends. From the bottom of the chart to the top, we have seen declines in not using seatbelts, current use of cigarettes, binge drinking, riding in a car with a driver who'd been drinking, and physical fighting. These trends in very different behavioral categories can be attributed to comprehensive public health approaches that intervene at the individual, family, school, healthcare, community, and policy levels. These approaches will be further described by Drs. Dittus, Michael, and Brindis today. In summary, the U.S. adolescent population is large and diverse, with important vulnerabilities conveyed by school dropout, poverty, and homelessness. These resilient members of our society are in good health, but they do experience preventable injuries and illnesses, and preventive care is underused. Adolescence is a period when all kinds of changes are occurring and risk behaviors increase. These risk behaviors contribute to both current and future health risks, but are amenable to public health intervention. I'd like to now introduce Dr. Patricia Dittus, who will continue our exploration of adolescent health. Thank you.
Thank you, Stephanie. Good afternoon. Adolescents are not mini adults, and they're in a near constant state of change as they transition from early to middle to late adolescence and into adulthood. Adolescents experience changes in physical, cognitive, and social emotional development that progress over time. Cognitive and social emotional development often lag behind physical development. Although many adolescents appear to be grown up, their brains are still developing well into late adolescence. For example, the area of the brain that controls executive functions, including weighing long-term consequences and controlling impulses, is among the last to fully mature. Adolescents' behavior is influenced by a number of factors within their environment or social context. At the intrapersonal or individual level are developmental influences, in addition to attitudes, beliefs, and knowledge. At the interpersonal or relationship level are the influences of family, peer, and romantic relationships. At the institutional level, we see the influence of schools and healthcare institutions. Schools, for example, have a positive health-promoting influence, but they also present opportunities for risk, as youth may form relationships with risk-taking peers. Next, community-level influences include neighborhood characteristics and community resources and norms. The society and policy level includes cultural, policy, and media influences. Most frequently, interventions focus at the individual level. However, we can intervene at all of these levels to reduce risk and capitalize on opportunities. In addition, evidence-based multi-level interventions can have a synergistic effect and maximize population-level impact. I'll provide some examples next of specific interventions. Families Talking Together is a parent-based intervention designed to support and improve communication between parents and adolescents about avoiding too early or risky sex. FTT consists of brief face-to-face sessions. 9 written modules are given to parents, and then booster calls follow up with parents after sessions are over. Healthcare providers or school principals can encourage participation by endorsing programs. Key parenting behaviors are targeted: communication about sex, monitoring and supervision, and the quality of the parent-adolescent relationship. FTT was evaluated in 2 randomized clinical trials with the mothers of Latino and African American adolescents in New York City, one conducted in 5 public middle schools and the other in a community health clinic. In the middle school study, at the 12-month follow-up, students in intervention schools reported significant increases in the amount and type of communication with their mothers about sex, as well as improvements in monitoring and relationship quality. That is relative to students in control schools. This slide shows percentages and means for the 2 key outcomes in the clinic study. Adolescents in the intervention group showed lower rates of transition to sexual activity across 9 months than adolescents in the control group, as well as less frequent sex in the last 30 days among those who were having sex. The average age of adolescents in this study was 13 years. FTT is the only parent intervention identified by the HHS Office of Adolescent Health as an effective intervention. The Community Preventive Services Task Force recommends interventions targeted to parents. Project Connect is a CDC-funded school-level intervention. It is designed to increase sexual and reproductive health care by connecting youth with healthcare providers in their community who are already providing recommended services to adolescents. A healthcare provider referral guide is distributed to youth. Key people in schools are also trained to make referrals to care. A large research trial was conducted in 12 public high schools in Los Angeles to evaluate Project Connect. Survey data were collected on 30,000 students in 5 yearly cross-sectional samples to assess school-level population effects. Students were predominantly Latino, their average age was 16, and 47% had already had sex at the start of the study. The intervention had significant impact on sexual and reproductive health care among sexually experienced females, but was not effective for males. Historically, males have been difficult to connect to health care. We are adapting Project Connect to determine more effective ways to connect males to care. This slide shows the percent of sexually experienced females who reported receiving testing or treatment for an STD across the 5 study waves. The intervention group reported an increase of more than 10% across the 5 years, whereas the control group remained stable. And although not shown, intervention effects were also found for the receipt of birth control from a doctor or nurse, or for ever having been tested for HIV. Project Connect is recommended as an effective strategy by CDC's Division of STD Prevention and Division of Adolescent and School Health. Communities That Care is a community-level intervention for reducing adolescent alcohol and tobacco use, delinquency, and violence. CTC guides communities in developing a strategic prevention plan. Key activities include a community-wide survey to identify priority risk and protective factors, forming a coalition of local stakeholders, and selecting from a menu of effective interventions for families, schools, and communities. Ongoing program evaluations and community assessments are an important part of the process. The Community Youth Development Study was the first randomized trial of CTC. 24 communities in matched pairs within 7 states were randomly assigned to receive the CTC intervention or to serve as controls. Because the CTC intervention was designed to affect adolescent behaviors, students were surveyed to determine intervention effectiveness. A panel of more than 4,000 fifth graders were selected, then surveyed annually through the 8th grade. Interventions were implemented for more than 2 years by the 8th grade assessment. This slide shows percentages and means for risk behaviors reported by 8th grade students in CTC and control communities. Students in the intervention were less likely to consume alcohol or use smokeless tobacco in the last 30 days, less likely to binge drink in the last 2 weeks, or to engage in delinquent behaviors in the past year than were students that were not in the intervention. CTC is listed on SAMHSA's National Registry of Evidence-Based Programs and Practices. Finally, a society-level intervention, graduated driver licensing, or GDL systems, seek to reduce motor vehicle crashes and fatalities among adolescents through a 3-tiered licensing system. First a learner's permit, then a provisional license, and then a regular driver's license. All states have GDL laws, although with varying additional restrictions, such as requiring a parent or licensed adult to supervise adolescent driving during high-risk hours, imposing a nighttime curfew, and restricting the number and ages of passengers. GDL laws in the U.S. were evaluated comparing fatal crashes among 16 to 17-year-old drivers to those among 19 to 20 and 21 to 25-year-old drivers. The quality of GDL laws was also included in the analysis, with good GDL laws being those that had 5 or more of 7 additional restrictions. Zero-tolerance alcohol laws were also assessed. These laws make it illegal for anyone under age 21 to drive with any amount of alcohol in their system. GDL programs reduced fatal crashes among 16 and 17-year-olds by 7 to 14% relative to older age groups. States with good GDL laws had fewer fatalities than states with poorer laws. In addition, states with a good GDL law plus a zero alcohol law among drivers had the fewest fatalities among adolescents. This study demonstrated that additional restrictions to GDL laws are important for further reducing fatalities among young drivers. As adolescents develop and experiment with new identities, they try out new behaviors, not all of which are healthy. Multiple levels of prevention can be layered to encourage adolescents to avoid risk and adopt health-promoting behaviors. We should continue striving to create ways to make healthy choices the easy choices. Now I will turn things over to Dr. Shannon Michael, who will discuss the importance of schools.
Thank you, Patricia. Good afternoon. Schools are a great place to promote adolescent health and wellness because the vast majority of adolescents attend school. There are over 37,000 middle and high schools in the U.S. that reach over 38 million adolescents. Schools are designed to be places for learning, including places for learning about health. Schools can also provide opportunities for adolescents to practice healthy behaviors that improve their health now and will lead to success in the future. We know that healthy students are better learners, and we know that academic achievement, especially high school graduation, conveys lifelong benefits for health. This gives education and health leaders a shared interest in promoting adolescent health. Today, I will focus on 3 important ways schools can impact the health of adolescents. First, schools can create environments that are safe, positive, and supportive of healthy behaviors. Second, schools can teach adolescents about healthy behaviors through health education and physical education. And third, schools can provide health services, including mental health services, for adolescents. Within the school environment, school climate refers to the quality and character of the school that directly impacts the students' experiences, including motivation to learn. A positive school environment serves as a protective factor in preventing or reducing risk behaviors, including reducing bullying and harassment. School connectedness refers to the relationships students have with their peers and teachers and to parents' engagement in the school. Adolescents who feel connected to their school do better in school and are less likely to engage in risky behaviors. Finally, evidence-based health policies and practices provide opportunities for students to become health literate and choose healthy behaviors, let's look at how school health policies and practices directly impact the school environment in the area of nutrition and physical activity. While almost all school districts have local school wellness policies that set goals for nutrition and physical activity, the quality and level of implementation of these policies varies. New federal requirements aim to hold districts accountable to monitor school-level implementation of the policies. CDC's school health guidelines to promote healthy eating and physical activity can assist districts and schools in identifying evidence-based policies and practices to include in their wellness policy. This resource identifies 9 evidence-based guidelines and 33 strategies to improve healthy eating and physical activity among students. CDC uses the School Health Policies and Practices Study, or SHIPS, to track how well we are doing nationwide in implementing health policies and practices in schools. Data from 2014 show that less than 20% of schools have vending machines, school stores, or snack bars that sell foods and beverages high in fat or added sugar. But they need to work on providing students the opportunity to purchase healthy foods such as fruits or vegetables. We see that about 75% of schools let students carry water bottles during the day. However, about 25% allow advertising of soft drinks on vending machines. There are many ways schools can increase physical activity during the school day. An example for physical activity from the 2014 data, we see that nearly 90% of schools are following national, state, or district physical education standards. But very few schools are offering daily physical education. We see that schools are doing a good job of offering recess during school, but more schools could offer physical activity breaks during the school day. CDC has provided funds to all 50 states and DC to build capacity for improving school policies and practices. Because of this work, we hope to see more schools using evidence-based practices to impact the health of adolescents and improve their well-being. Let's turn to health education and physical education as a second important area for schools to improve adolescent health and wellness. Health education is an integral part of education. It consists of planned, developmentally appropriate learning lessons and experiences on a variety of topics such as nutrition, physical activity, alcohol and other drug use, sexual health, tobacco use, injury and violence prevention, and mental and emotional health. Health education provides adolescents the opportunity to acquire health knowledge and skills that will help them make informed health decisions throughout their life. Health education increases condom use, improves BMI, and decreases smoking. Daily physical education in school equips adolescents with the appropriate knowledge, skills, and confidence to be physically active for a lifetime, and help them meet the nationally recommended 60 minutes of daily physical activity. Schools should not only be offering physical education, but also keeping adolescents active during class. The Institute of Medicine, CDC, and Shape America recommend that all middle and high school students should spend 225 minutes of physical education per week. In addition, they recommend that students should spend at least half the class time for physical education engaged in moderate to vigorous physical activity. In support of students engaging in physical activity, the Community Preventative Services Task Force recommends enhanced physical education. Enhanced physical education increases the amount of time students spend in moderate to vigorous physical activity during physical education classes by improving teacher strategies and supplementing students' participation in sports, such as baseball with activities such as running or jumping. Schools can receive support for physical education from 2 national initiatives. The First Lady's Let's Move Active Schools initiative helps schools develop and implement physical activity plans and programs with a strong focus on physical education. The Presidential Youth Fitness Program improves fitness education through teacher training and fitness assessments. Finally, schools can impact the health and wellness of adolescents by providing healthcare services, including mental health. A recent case study of the Massachusetts Essential School Health Services Program examined the cost-benefit of school nursing services delivered by full-time registered nurses. The program costs were $79 million. The cost averted included medical care costs and productivity loss of teachers and parents. The net benefit was $98 million. This means that for every dollar invested in the program, $2.20 was saved. Beyond having a school nurse, comprehensive health services can be provided through a school-based health center. These services help keep adolescents healthy and in the classroom. The Community Preventative Services Task Force conducted a literature review of these centers. The review found that school-based health centers were associated with improvements in health-related outcomes, especially for urban, low-income, and racial ethnic minority high school students. The findings also showed that school-based health centers were associated with improvements in educational outcomes, including grade point average and suspension rates. Based on these findings, the task force recommends the implementation and maintenance of these centers in low-income communities. As an example, Denver has 16 school-based health centers offering primary care, mental health, and full reproductive health services that include STD testing and treatment, comprehensive health education, and pregnancy testing. 13 of the 16 centers dispense contraception based on the discretion of the principals. These centers also connect adolescents to other essential services outside of the school by making an appointment with a health educator in one of 8 community clinics. Data indicate that adolescent birth rates declined by 40% in Denver from 2009 to 2013. While there are many factors that may have contributed to this decline, an important factor was providing Denver adolescents with medically accurate and comprehensive sexual health education. Interestingly, school dropout rates also declined during the same period. Schools can impact adolescent health and wellness by creating healthy school environments, teaching health education and physical education, and providing school health services. Together, we can increase these opportunities and, more importantly, their quality. Now we'll learn more from Dr. Claire Brenes on improving health care for adolescents.
Thank you, Shannon. Adolescence is a key time when young people become increasingly responsible for their own health care as part of their growing independence and transition into young adulthood. Healthcare systems can be designed to address the risk-taking behaviors that can increase during adolescence and that can lead to major health problems. Today, I will share with you ways to improve both preventive and treatment services for adolescents. Improving healthcare for adolescents includes improving access to and use of clinical preventive services, taking advantage of opportunities provided by the Affordable Care Act, or the ACA, designing systems interventions to improve population health, and ensuring that healthcare services are youth-friendly. One challenge is assuring that adolescents receive clinical preventive services. Data show relatively poor delivery of 3 major recommended health services. Less than half of adolescents have an annual WellCare visit. The data also reflect variation in delivery by type of insurance coverage. 55% of adolescents in the Medicaid program received chlamydia screening, compared to only 41% of adolescents with commercial insurance. Looking further into who accesses health care, we found income, racial, and gender disparities. While overall 43% of adolescents had a preventive health visit, only 38% of those living in poverty were likely to receive such services, and only a quarter of those who lacked health insurance received a preventive visit. There were also important racial disparities, with 37% of Hispanics receiving preventive health visits, while 43% of non-Hispanic blacks and 45% of whites had access to these services. National guidelines exist regarding screening and counseling for a variety of risk behaviors. However, fewer than 1 in 3 adolescents receive anticipatory guidance for seatbelt use, helmets, and the risk of secondhand smoke. Given current childhood and adolescent obesity rates, slightly less than half received anticipatory guidance regarding healthy eating. Only 1 out of 10 received anticipatory guidance on all 6 recommended prevention topics. We now have a unique opportunity to close the insurance and healthcare gap for adolescents through the ACA. First, the ACA has increased the number of adolescents with insurance coverage, even if they've had a previously diagnosed health condition. Second, the ACA has increased the number of adolescents with a consistent provider of care, referred to as medical home. Third, the ACA has increased access to preventive services by incorporating clinical guidelines and anticipatory care. And finally, the ACA can provide a bridge for the transition from pediatric to adult medical care, a critical time to establish ties with primary care clinicians. The ACA has increased insurance coverage for many adolescents through the expansion of Medicaid for low-income populations. 30 states have expanded Medicaid eligibility. For other adolescents, health insurance exchanges have been established by the federal and state governments through which eligible families can access coverage. And an important element in the ACA has been coverage expansion for adolescents and young adults up to age 26 on their parents' health insurance plans. The medical home is a key element of the ACA, aimed at reducing fragmentation through improved coordination of care. Data from 2007 suggests that this is an important gap to fill. Only 54% of all adolescents were affiliated with a specific medical home provider. Fewer than half with a mental health condition had a medical home, and about a third with both physical health and mental health conditions had access to such services. A requirement of the ACA is the provision of preventive health care services without cost sharing, utilizing clinical guidelines. Specifically, the U.S. Preventive Services Task Force A and B recommendations, Bright Futures guidelines for children and adolescents, the ACIP immunization recommendations, and the Institute of Medicine's recommendations for women's health, which includes an annual preventive health visit. With the incorporation of medical homes, adolescents will more easily find adult primary care providers as they begin to age out of traditional pediatric practices. This offers adolescents opportunities to learn how to use the healthcare system more effectively and gain skills as active health consumers while increasing their health literacy. This is an area for health system improvement, as only 40% of 12 to 17-year-olds report that they had had time alone with their provider during their most recent visit. The ACA can only achieve this promise if certain challenges are addressed. Adolescents or their parents might not enroll in health insurance. If they do enroll, they might not seek preventive services. They might live in states that have not expanded coverage, and thus may not have access to affordable coverage. And they might need but not seek sensitive services such as for sexual and reproductive health or substance use due to concerns about confidentiality. Given the need for improved adolescent health and the opportunities afforded through the ACA, what options exist to improve adolescent health care? As an example, Kaiser Permanente in Northern California and researchers from UCSF conducted a comprehensive system intervention to increase the provision of clinical preventive services for adolescents ages 14 to 17 in 6 different areas, including safety-related issues. The intervention entailed several components. The numbers and types of health care visits adolescents already made were shared with clinicians, demonstrating many opportunities for providing clinical preventive care. Pediatricians and nurse practitioners were trained to increase their capacity to screen for and counsel adolescents about a variety of health risk behaviors. Providers were given specific screening questions and scripts tailored to individual patterns of risk-taking behavior, including affirmation of positive health behaviors and anticipatory guidance. Finally, some services were shifted to health educators who provided clients education and counseling about how to change potentially risky behaviors. These data demonstrate the changes in screening and counseling practices after the intervention, comparing intervention and comparison sites. In this slide, I highlight the findings in the area of safety, given its impact on adolescent morbidity and mortality. Following the training intervention, screening and counseling rates in intervention sites increased across all targeted risk areas. For seatbelt use, screening rates increased from 43% to 82%, and counseling rates increased from 44% to 85%. Seatbelt screening decreased in comparison sites during the same time period, while counseling increased, but far less than in the intervention site. This study demonstrates the efficacy of provider training and how it can improve preventive services with adolescents. A variety of factors contributed to the improvements. The intervention was supported by health system leaders, such as the outpatient director, and other system champions, including nurses, ancillary staff, and lead clerks. An important partnership was forged between academic leaders and health plan experts. They conducted joint training and capacity building to incorporate patient support materials as part of the patient visit. There was a rigorous evaluation to assure clinic-wide implementation with fidelity. All of these factors led to a substantial change in the culture of incorporating clinical preventive services. So what difference did these changes in screening and counseling services make for the adolescent patients? As shown in this slide, the intervention had the most dramatic effect on adolescents in the area of helmet use. There was a 140% increase from age 14 to age 15 in the intervention sample. As we pursue new interventions, we also have to consider principles which guide youth-friendly healthcare. These principles are assuring availability of healthcare, for example, minimizing the length of time to wait for an appointment, providing appropriate healthcare that is developmentally tailored to the needs of early, middle, and late adolescents, assuring accessibility, such as transportation and ease of use, approachability, which pertains to whether the environment is welcoming to adolescents, and acceptability of the experience for adolescents. Are they treated with respect and in a non-judgmental manner? There are two additional issues that shape healthcare delivery for adolescents. First, the issue of confidentiality pertains to maintaining information private that patients disclose to their healthcare provider. Providers have limits on how and when this patient information can be shared with others. Traditionally, they're able to share health information only under limited circumstances, particularly if the young person is at risk for themselves and others. Second, minor consent laws enable minors to consent for some types of health care. Laws vary tremendously between states regarding whether adolescents are able to give consent for a variety of sensitive health care services. For example, for screening and treatment for sexually transmitted infections, mental health counseling, substance abuse services, and reproductive health services. Consent laws and confidentiality are important to adolescents' primary concerns and privacy concerns. Before the visit, privacy concerns might affect whether the adolescent sets up an appointment. Due to the variability of state laws, it is important in your role to understand the confidentiality and consent laws in your state so that you can provide guidance and information to adolescents as they seek information about accessing services. During the visit, the content of the care provided is particularly important to adolescents. Research has shown that assurance of confidentiality is vital in terms of what adolescents are willing to disclose to their providers and also impacts continuity of care, especially for sensitive services. After the visit, adolescents are especially concerned about who will have access to their healthcare record. They're also worried about whether an explanation of benefits will be sent to the primary policyholder, revealing the sensitive nature of a medical care visit. A number of states, including California, and some insurance systems have begun to develop new policies enabling clients of all ages to request that their documentation related to sensitive services be sent to an alternative address or email. There are 6 important strategies to pursue as we seek to improve adolescent health care services. First, we must enhance the capacity of providers to deliver quality screening, assessment, management, referral, and specialty services. Second, healthcare providers work within systems of care. These systems need to recognize the importance of investing in adolescents' lives, particularly as they transition into adult health care. Thus, we need to systematically incorporate health promotion, disease prevention, and youth development throughout the healthcare system. Third, we must coordinate services in practice and community settings, as well as coordinate physical and behavioral health services. As adolescents engage in a wide variety of community settings, including schools, health providers have a role and a responsibility to play in helping to assure coordination of care. Fourth, providers and systems can play an important role by helping to assure adolescents' active participation in health care, including consent and assuring them confidentiality of care for sensitive care. Fifth, the health and service needs of adolescents who represent vulnerable groups, such as foster care and low-income youth, need special attention by health providers and systems of care. Sixth, actively engage young people in the shaping of the types of health services and the manner in which they are provided. As we've discussed today, adolescents make up a large part of our population and are the future of our society. Preparing them for lifelong health and wellness is crucial to assure they are healthy now and have long, healthy, and productive lives. Their developing brains make this period challenging, but also ripe with opportunity to instill healthy habits. Parents play a crucial role in the health and wellness of adolescents. Talking to their kids, staying connected to their kids' schools, and giving them time alone with their doctors are a few things parents of adolescents can do. Adolescents spend an enormous amount of time in school. This is an important venue to assure the opportunity to learn about health, to participate in physical activity, and to spend time in healthy environments. The healthcare system can better engage adolescents to understand their risks, provide teen-friendly care, and assure their access to and use of preventive services, sensitive care, and confidential care. And we can take community-level action to assure our adolescents have safe and supportive environments in which to grow and where the healthy choices are the easy choices. Together, we can help adolescents prepare for lifelong health and wellness. Thank you very much. And now we are happy to move into a question and answer period, which will be led by Dr. Zaza.
Okay, we have time for a number of questions. So while people are coming to the microphones or raising their hands, I'll start with our virtual audience.
Yes, from our online audiences, what sort of adaptations are being made to Project Connect to increase effectiveness towards males?
That's a great question. We have conducted a couple of studies and are in the middle of a couple right now. We're looking at it from a couple of different sides. So one is on the provider side, and that is identifying providers who are adolescent male friendly, including for young men who have sex with men, so particular providers who are best suited for addressing males' needs. And then on the other side is helping people who have regular contact with young men to better recognize the sexual and reproductive health care needs of young men and getting them in a better position to be making those referrals to care.
Do we have another one?
We do, more from our online audiences. What are your recommendations to people for preventing drug addiction with teens, or actually drug abuse?
Well, I'll start with that one. I am not aware that we have any particular recommendations from CDC for youth, but we can certainly find that out and follow up with the questioner. But I think that some of the approaches that we've talked about here today are translatable. So the idea of health education, of course, in schools, substance use is an important topic that we should include. I think we also need to think about referrals, sort of being able to recognize the signs or youth who might be at risk and move them quickly into treatment. And we also need to think continuously about the environment that our young people are in and to make sure that those are safe environments. So this sort of set of approaches, I think, can be translated. But I'd be happy to hear about specific recommendations from either other agencies or from other parts of CDC that might have them. Okay.
In addition to what Stephanie just shared with us, I think it's really important to look at policies that are in place and whether drug treatment services are actually available, the kinds of therapy that can be provided in a co-located school setting or an after-school program, and ways that we communicate to the public about the importance of this issue and its vitality in terms of the future of this young population.
Any questions from in the room? I'm not seeing any hands yet. So, Susan?
We have one viewer that would like to hear more about rural youth. Can you expand on some of this as it might apply to rural communities?
Well, one thing I can share is that in the communities that CARE studied, the community level intervention, that did include both rural and urban communities, so it was applicable to a wide range of community settings.
And there's been some studies looking at physical education in different settings, and what we know is that regardless if they're in a rural or an urban setting, that having the opportunity to have physical education is beneficial, regardless of where they live.
Oh, yes, Rich, at the back of the room.
Thanks for a great presentation. I was wondering if there are any examples of best practices that you could share for health departments working effectively with schools.
That's a really great question. Actually, we currently fund all 50 health departments to address physical activity in schools, nutrition in schools, and chronic conditions in schools. And we're working from the whole community, the whole school, whole community, whole child model, and that really addresses what we call that was formerly coordinated school health, and what we do is we focus on the kids, and we align, the health departments are helping schools develop those policies and practices that will help kids choose those healthy behaviors.
I would also add that we do have documents that help schools work with health departments and vice versa. So we have how to work with schools and how to work with health departments. So being able to help people connect through our various grant programs. So on the one side, we're focusing in DASH in the Division of Adolescent and School Health in funding school systems and ask them to develop a memorandum of understanding with their either local or state health department. And vice versa, the school health branch is working with health departments sort of to bring this together from both sides. So we do have pieces that help on both sides of that equation to make those relationships work, and funding on both sides of the equation as well.
And what we've been able to see that health departments that are working with the state health departments that are working with their state education departments, that's where we're seeing really great success happen.
Can I also offer one more thing? I think in addition to these answers, health departments are really the leaders in their communities, and they have oftentimes very strong relationships with networks of community-based organizations. And that reach is really important to also include parents as well as youth who may not be enrolled in school, as well as thinking about the youth in a very comprehensive way. So for example,
health departments that are really focused on increasing the number of young people enrolled in health insurance have been working with a network of safety net providers to be sure that there are enrollment workers in those settings that can also maximize the number of enrolled individuals in health insurance.
Robert?
Robert Hahn, Community Guide. As you're well aware, there are large gaps in the health and educational outcomes of poor and minority children in the U.S., and poor and minority schools often lack resources for many programs. As you're aware, we've done a study showing that school-based health centers, of which there are not enough, 2,500, are one way to address this. I'm just wondering what other ways your program might have or consider to address the needs of poor and minority children and schools.
Well, we would all like to have a magic wand that expands the number of school-based health centers for underrepresented minority youth who may be living in low-income communities. But I think we can think about schools in another kind of way, which is that they play a very important partnership role in assuring referrals and identification of resources. Many of our families may not recognize that they're actually eligible for services, and having informed school staff, and that can include teachers, it can include the psychologist, it can include the bus driver who is aware of the kinds of services that there are in the community, and really helping to link and knit what goes on in some of these communities that have both resilient factors as well as weaknesses.
I would also add that I think, at least from the federal funding perspective, which is what I can speak to with the most confidence, is that we're asking our grantees to identify priority schools. And in most cases, those priority schools are in communities that have these kinds of socioeconomic challenges. And so I think that what we're learning from those, because we're not funding everywhere and the states are not able to fund every school district, we're getting to really learn what works best in those kinds of communities so that we can begin to build a repository of information that will allow us to then provide that kind of technical assistance, if not funding, in the future. So trying to really build a community of knowledge around this issue of how to best work with poor schools and to help them link to health services in particular that are in the community, knowing that there's such a lack of school-based health centers, I think is really one of the most important things we're learning during this funding cycle. Are there any other questions, Susan?
From our Grand Rounds email box, I'm shortening this in the interest of time. Could the panel address issues concerning wellness not only for healthy adolescents, but adolescents with illnesses? We need to address the often forgotten ill struggling to be healthy, get healthy, or doing the best they can with their particular challenge.
So, as I mentioned, we're funding state departments of health to address chronic conditions. And one project that we're working on is working with parents, and it's called Parents for Healthy Schools. And what we're doing is providing information to parents to be the child's advocate, to go in there and to share with the school, these are the issues my child is struggling with. I want to make sure that my child has the best opportunity to succeed in school, and to do that, these are the services that we hope to receive in the school system. And I know you probably.
I was going to say, and also I think that apart from parents playing a role as their child's advocate, is also having teachers and other school personnel who can really continue to reaffirm and affirm management, chronic healthcare disease management, which really supports the young person. That young person may feel extremely isolated, and the school environment becomes a very important key for really providing the kinds of educational supports, psychological supports to help that individual manage well or better their chronic health condition. And we need to recognize that many children now are able to survive into the adolescent years. So about 17% of adolescents are adolescents who have a type of chronic health condition. So this is more common than traditionally we can think about.
Thank you. Dr. Thorpe?
And thank you very much. And thank you for joining us. Join us next month.